Um, in a minute, I'm going to ask Dr. Merjanian to introduce our grand round speaker. But first, with regard to the WebEx, we'll be taking attendance using the participants list at 8:10. I've already seen a couple of people who only have their first name, but it's very important to our department to know who is in the WebEx. So please, people, if you could put your last name, unless you have an incredibly unique first name. Also, people who are on the phone, if you'd like to get credit for attendance, you can email your name to Michelle or Beth or I. And with that, Dr. Merjanian, are you ready to introduce our speaker?
I am. Can you hear me?
Yes, loud and clear.
Good morning. So I have the pleasure of introducing Dr. Alopi Patel, who is an associate professor in the Department of Anesthesiology here at Rutgers Robert Wood Johnson Medical School. Dr. Patel is a double board certified anesthesiologist and interventional pain physician. She attended New Jersey Medical School. She's also certified in lifestyle medicine and encourages the implementation of lifestyle modifications in the treatment of chronic pain conditions. Dr. Patel launched a podcast called The Hurt by the Female Pain Docs, which is meant to empower and educate patients regarding their health on topics within anesthesiology, pain medicine, and lifestyle medicine. As a faculty member, Dr. Patel is actively engaged in clinical research projects and has given lectures in regional and national conferences on topics in perioperative and pain medicine. I look forward to hearing her talk on non-obstetrical causes of pain in pregnancy and also collaborating with her in the future on patient care.
Good morning, everybody. Can you hear me okay?
Yes.
Loud and clear.
Excellent. And you can see my slides okay, correct?
Yes.
Okay, excellent. Thank you so much for welcoming me to present today. It's an honor, and I've worked with some of you already, and I've really enjoyed my few months that I've been here, and I look forward to collaborating more. So today we're going to talk about the biomechanical changes in pregnancy, many of the pain conditions that that women see during pregnancy, as well as how I can help and how I can help manage these patients during the pregnancy period. So as a pain physician, I see, and I specifically specialize in women's health and pelvic pain, but as a pain physician, I see women from all across their life cycle. And one of the things I like to remind my colleagues, my fellows, is that the life cycle of a woman is very different than the life cycle of a man, as we all know in this audience particularly, but especially also when it comes to the different pain conditions that women face in their life. There is no subspecialty in women's pain within the field of pain medicine, but it is something that I've adopted and learned a lot about over the last several years that I've been in practice. And this is a slide that I put in almost every lecture that I give, just to remind everybody that it's not a level playing field when it comes to the hormonal aspect of pain processing, the anatomical, physical changes that women go through throughout their life. So just a little overview of the common pain syndromes. Women can face migraines, fibromyalgia, interstitial cystitis, pelvic pain, TMJ, and all sorts of different conditions at higher rates than men. And particularly, pregnancy is a unique condition that can cause pain, as well as the sequelae of pregnancy, which we will speak about during this talk. So pain in pregnancy, this is slightly outdated, but this was a good survey that I found from about 10 years ago. A survey of 500,000 pregnant women in the United States saw that 14% of women filled a prescription for opioid at least once during the antepartum period, and 6% received opioids throughout all trimesters. As we know, the landscape of opioid prescribing, as well as the landscape of pain medicine, has been very much at the forefront in terms of how we are treating the opioid epidemic, as well as how we are able to incorporate other aspects of pain management without putting patients at risk for opioid use disorder. So there is a high incidence of pain syndromes, as we know, during pregnancy, but also increasing use of opioids for pain during this period. So how can we manage a patient's pain without not just opioids, but also using opioids when they're indicated? So that's what a lot of this talk is going to be about. As always, and I feel like I'm going to say this many times throughout the presentation, so just bear with me. As always, as you know, as OBGYNs as well, rule out any true obstetric causes. And even when I see patients during pregnancy or postpartum, I'm always mindful to make sure that we're not missing anything else. And especially during pregnancy, is there anything else that could be causing their pain that could be due to other obstetrical emergencies as well? So the types of changes that happen in pregnancy can be anatomical or physiologic in terms of hormones. So as we know, pain can be initiated during pregnancy due to a lot of these biomechanical changes. It can be worsened during pregnancy, again, due to these biomechanical changes, or made better during pregnancy, which we'll speak about as well. And they can even cause disability. And again, this is a slide from one of my other lectures that I like to kind of put in here and remind, why do some of these changes happen? And why do some of these changes actually make pain better? So as we know, again, with cyclical hormonal changes for non-pregnant women, there are times of the month due to these estrogen fluctuations that pain can get better during the month for a few days, or pain can get worse for a few days during the month as well. So all these hormonal fluctuations now stabilize during pregnancy. So certain pain conditions can get better, such as migraines, which we'll speak about, whereas other pain conditions can get worse, which are more associated with the musculoskeletal system. So causes of pain can be multifactorial. Most of the ones that we'll focus on today's lecture are musculoskeletal, which is my area of expertise. They can also be associated with rheumatological conditions, neuropathic, pelvic conditions, abdominal, and headaches. So again, as many of you know, I'm not going to spend too much time on this slide. There are many different changes that happen during pregnancy that are normal in terms of weight gain, the shift in gravity. All of this can cause, again, a change in biomechanical aspect of the body. So this can cause exaggerated lordosis, weakness and separation of the abdominal muscles, widening of the pelvic joints and the pubic symphysis, gait changes, fluid retention. So all of these is essentially what can initiate a lot of the musculoskeletal pain syndromes that we're going to discuss. And then of course the hormonal changes, so the relaxin, which is associated with the relaxation of the pelvic girdle, progesterone, as well as estrogen. So what is the impact of all of these biomechanical changes that happen? So again, we know that there's exaggerated lordosis, forward flexion of the neck, downward movement of the abdominal muscles. How does this manifest for patients when they present to the pain office, right? So oftentimes we see this in terms of muscles, bone, and nerves, which I'll speak about in a few slides as well. But a lot of times when we see these anatomical changes, we understand that there could be a strain in the paraspinal muscles, strain in the abdominal muscles. Joint laxity from that relaxin can again cause joint pain, and the forces across some of the joints and the body are actually increased as well. There's instability of the lumbar spine. Again, this can cause a lot of the lower back pain, widening of the pelvic girdle, causing pelvic girdle pain, anterior pelvic tilt, again, causing that change in center of gravity that's now associated with foot and ankle pain as well. And then fluid retention can cause peripheral neuropathies such as hand, foot, and rib pain. So again, many different musculoskeletal causes, and we're going to go through many of them in detail. So low back pain is probably the most common. Seems like my light went off. Okay. So low back pain is the most common. The numbers vary significantly in terms of the rates. I've seen rates from 60% to 90%. I feel like almost any of us that have been pregnant in the audience can say that we've all had some degree of back pain. So I'm pretty sure the numbers are pretty high up there in terms of how many women have had back pain during pregnancy. In terms of the causes of the back pain, that is very variable. Now, risk factors for back pain can include higher parity, higher BMI, pre-existing back pain, and up to 43% can continue to have lower back pain at 6 months postpartum. And the other thing I want to note that for patients who have had previous pregnancies, who may have had labor epidurals. This is something that I've routinely seen in the office as well. They say, well, I had the epidural and, ever since I had the epidural, it's, I have back pain. And I'm sure many of you have heard that as well in your offices that, people say that they had a labor epidural and ever since then they have back pain. So they have done retrospective studies on this, and there are many different causes for why they may be having back pain. But Usually, for the most part, and we'll discuss this as well, oftentimes this is because of the changes in anatomy, including their pelvic girdle, and that can cause a lot of those pain syndromes and referral patterns. So what are the causes? As we discussed, there are many different mechanical causes. When I see pain patients, I like to do a lot of patient education. One of the ways I kind of discuss what's going on is how is the body responding to things. So there's muscles involved, nerves involved, bone involved, and tissue involved. Oftentimes with the mechanical changes of pregnancy, it's an interplay of muscles, nerves, and bone. So specifically for back pain, I kind of work them through that differential as well. So discogenic pain is something that is type of pain that comes from the disc. We can see discogenic pain at any part of pregnancy, but more towards the end of it sometimes as there's more strain. Discogenic pain can be pain that gets worse with straining, defecation, coughing, forward flexion, and whatnot. Treating discogenic pain might be different than treating something like sacroiliac joint pain. Another common cause of back pain, lower back pain, not as common as discogenic pain, is lumbar plexopathy. So again, this is due to the compression that can happen around the nerves of the lumbar plexus, and less common than discogenic pain in towards the end of pregnancy. Then we have sacroiliac joint pain. Oftentimes, the sacroiliac joint, many times patients will say they have pain. They'll put their hand on the back right over that posterior, that PSIS, this posterior superior iliac spine area. And then spondylolisthesis, which is the movement of the vertebral bodies over each other. Coxodynia, which is tailbone pain as well. So these are some of the ones that we could see, but most commonly, usually it's associated with discogenic pain. And again, we want to rule out any physiological causes of back pain, such as pyelonephritis or other kidney issues. So how do we work up these patients? So we do a thorough history in terms of what makes the pain better, what makes it worse. We know that certain types of pain conditions, like leaning forward, can get worse if it's associated with discogenic pain. There are certain types of pain syndromes that can get better when they lean back, such as certain types of muscle-related pain. So again, those are very non-specific markers, but we still want to know what makes it better, what makes it worse, what types of movement and whatnot, coughing, straining, all of those. Oftentimes ends up being a very strong myofascial component, but also we want to rule out any discogenic component, which would be from either disc bulging, disc herniation. If patients present with this lower back, but also leg pain, we call that radicular pain. If there's numbness, tingling, or other sort of motor weakness associated with it, that's called radiculopathy. So again, we want to tease out what levels are involved. So if they do have radicular pain or radiculopathy, we want to know what levels are involved. If this is associated with the disc, is this a disc herniation or a disc bulge potentially at L4, L5 level or L5S1? These are the common areas that are affected, and this will often cause pain radiating down the leg, again, along these dermatomes, as you can see, which is L4-5, which is the anterior knee and the anterior aspect of the leg, and then L5S1, which is the anterior part of the leg, as well as the side of the foot. We don't routinely recommend imaging. If patients do come in with radicular pain or radiculopathy, we do a thorough history and a physical. Oftentimes a physical will give us a good amount of information in terms of doing a good dermatome and myotome assessment, but we don't routinely, obviously we don't send for x-ray, but even routinely, we don't necessarily send for MRI. Unless there is a risk or concern for cauda equina syndrome. So again, that would be something that would be more along the perineum if they're starting to exhibit signs of major motor or sensory loss, then we would consider an MRI, but usually we don't recommend, or we don't routinely send them for MRI, and definitely not CT. So how do we manage these patients for lower back pain? So again, we kind of tease out what is the cause of the pain, but even after understanding what is the cause of the pain, we kind of target conservative treatment. So again, a lot of this is patient education in terms of ergonomic modifications, heating pads if it's muscle related, massage. Oftentimes prenatal massage is something that we'll recommend if it's muscle related. However, we do advise in the office as well to avoid pressure points that induce labor. I used to live in New York for several years, and there were several walk-in massage locations that I used to go to when I was pregnant, but I would always tell them to avoid the feet. And I tell patients the same thing, avoid the feet if you're going to get a massage. And I have some of those points over here that can potentially induce labor. Light exercise, light walking. If they have access to the pool, I tell them to do light walking in the pool as well. PT, OT, as well as potentially manual therapy. But again, only with trusted providers and not doing anything that could, again, induce labor or cause further damage. Acupuncture, again, is great, but again, avoiding points that would induce labor. Water therapy we spoke about, as well as potentially TENS unit. So I will say, I will mention TENS unit throughout this talk, but with the precaution that TENS unit is not recommended over the abdomen in certain parts of the back. And I do tell the patients that if it's a certain area that's a muscle spasm, I will examine that area and say that they can put it over there, but not in all locations. And again, we counsel patients on this, and I know that there's some controversial evidence, whether it helps or not. But again, it's one of those risk-benefit analysis conversation that we have with patients. Yoga, I'm a big fan of yoga. Peloton has a great series on prenatal and postnatal care and yoga. And personally, I use them with both of my pregnancies and they were great. And I tell patients the same thing, YouTube exercises or go to the PT and get these different types of exercise that you can do at home as well. Supportive belts, which we'll discuss as well. Again, pelvic girdle support. And then analgesics and injections, I'll spend a few minutes on as well. So analgesics, very broad term, but things like acetaminophen, we don't routinely recommend anti-inflammatories, and then injections. So injections can vary. Sometimes I would say less than a handful of times done trigger points on pregnant women. Again, it's a risk-benefit analysis. I don't routinely do it. It would only be if they've tried everything and they're just like, I have this muscle pain that just won't go away. So I'll discuss some of those as well. And if I ever see a patient who's either in the process of trying to get pregnant or is in early in pregnancy and they happen to be seeing me and I know that they're pregnant now, I recommend early physical conditioning during pregnancy. We all know in this audience that early physical conditioning is great for many different reasons and also in terms of the development of chronic pain and pain exacerbation during the pregnancy. So medications are a hot topic. I'm sure all of you have seen some of these in the news recently, acetaminophen, and the risks associated during pregnancy. And, it can be very triggering as women who are pregnant when we have pain and we are very limited in terms of what we can take. So I'll discuss a little bit about that. And some of you may already know this in the audience. Maybe this is a good review for the residents as well, but there was an old system that we used in terms of the FDA drug risk classification, in terms of categories of medications and their safety during pregnancy. Since then, this labeling has changed. There was also an older system for lactation in terms of safety during lactation. Both of these systems have recently changed since 2015. I guess that's not recent anymore, almost 10 years now. Feels like it was just yesterday, but so the current labeling now, it has to do with basically a risk-benefit analysis. They came out with this big paper in terms of the old system is gone, no more categories, no more, lettering and all of that. But it almost made it a little bit more confusing in the sense that the lettering is now not just category A, B, C, D. It's more of like a risk-benefit analysis. Read the fine print on every medication, discuss with the physicians in terms of, what their options are. So it can be a little bit more confusing for patients as well. But again, it does encourage collaborative care amongst all the physicians. So this is basically how medications are now are summarized, their risk summary, and then all of these big words that can be terrifying to patients. I still generally refer back to the category so patients have a better idea of how to understand them. But again, I tell them it's a risk-benefit analysis. So I'll still keep in the older categories of some of these medications just to kind of make it easier to follow. But acetaminophen, again, we've seen a lot of buzz in the news, but still overall they're safe to take. And these used to be category B, and they're potentially, from older literature, similar analgesia to NSAIDs. So for patients who do have aches and pains and are terrified to take any medications, if they need it to prevent disability and prevent immobility, I do say that it's okay to take, and encourage them to take the lowest dose as possible, but if needed, they can take it. NSAIDs, as we all know, are typically contraindicated, but in low amounts can be used in the first and second trimester. I work very collaboratively with my referring physician, so I always like to communicate if they do take it or if they're or thinking about taking it, to speak with their OB and confirm that it is actually okay and that we're all on the same page. In terms of neuropathic medications, so all of the neuropathic medications essentially are category C or D. That doesn't mean that patients can't take them. This is, again, a risk-benefit conversation. Gabapentin or amitriptyline sometimes are medications that some patients may need to take for a short period of time. Again, depends on the trimester of pregnancy. But if they have terrible neuropathic pain and it's causing disability, then risk-benefit analysis is necessary. Steroids are also very variable. In terms of which steroids, I have, again, less than a handful of times during the third trimester, essentially, recommended a short course of steroids for somebody who had a new disc herniation during the third trimester. So again, steroids can be risk-benefit analysis. I converse with their OB and make sure that, it is a safe course of action. But overall, we all know that we want to minimize the use of medication that may have any potential harm developing the fetus during the course of pregnancy. What about opioids? So opioids are probably the biggest medication that has a lot of attention on them right now, right? So we know that opioids are generally safe during pregnancy. Most of the older literature has shown us that it's mostly category B and C. There's no major risk of malformation, but there is the theoretical risk of neonatal withdrawal syndrome after birth. And again, the CDC as well as ACOG has come out with more information about this, that, it's okay to take certain types of opioids for a limited amount of times. We also don't want women to suffer if they do have pain. But of course, there is a risk. More of that counseling is done for patients who are on chronic opioids. But again, I have one slide on that towards the end of the presentation that we'll discuss as well. So interventions. A lot of my patient interactions actually are often sort of around, I don't know why my office light keeps turning off. So a lot of my patient conversations revolve around patient education. I like to set realistic expectations. I like to empathize with them, guide them, counsel them, give them a sort of understanding about what is going on, why this is happening, and what they can do about it, as well as what we as a healthcare system can help with. So a lot of this is setting expectations. What is considered normal back pain? What is considered, bad back pain, which is causing radicular pain that might need steroids, that might need an epidural or something else. Now, I don't routinely do epidurals. I've probably done that on pregnant patients. I take that back. Outside of L&D. In the pain office. So I do not routinely do epidural steroid injections in the chronic pain office. I have done it once in the last 6 years that I've been attending. But again, this is with careful assessment and understanding the disability that the pain is causing. So if a patient does have true radiculopathy, radicular pain along a single nerve distribution, then it is something that we can do. We have seen in the literature that these can be done blind. We don't usually recommend them, but usually we'll assess with ultrasound. Routinely for non-pregnant patients, we use fluoroscopy, but we don't do that here. But we can do an ultrasound to get the right area in terms of getting L5S1, L4, L5. We can kind of go in the general area of where their disc herniation is and do an ultrasound-based epidural with steroids for their disc herniation or their discogenic pain. We don't routinely, well, I personally and the pain physicians don't do MRI-based epidurals, but there's been some literature that interventional radiology can do them. I'm assuming they do them in lateral DQ. So the sequelae of back pain that I was referring to earlier, many women after pregnancy can have chronic back pain, and this is overall mostly from the literature understood to be due to sacroiliac joint pain, pelvic girdle pain, and overall mechanical changes that happen in the axial spine. So this is a referral map of different types of areas that can be impacted by pelvic girdle pain. How often do you see this in postpartum, right? Almost all women have pain in this area. So oftentimes when patients present to me postpartum in terms of several months and they're still having pain, this is a very common picture that I see. And, it's pelvic girdle pain, and there are many different things that we can do with it. Oftentimes the sacroiliac joint, which we do right over here in these pink areas, are a home run for these patients because they need a good amount of conditioning, but getting them to PT and counseling them to continue it is the biggest part, but that sacroiliac joint injection with steroids can help them reach that. I think I'm doing good on time. So Okay, so headaches. Again, we want to rule out all of the bad stuff, right? So especially if this is beyond the second trimester and they have a new onset headache, we want to rule out all of the bad stuff. If there's any signs of neurodeficits, again, rule out the bad stuff. If this is another bread and butter, and I use that very generally, sort of headache, then most of the time it ends up being a tension headache in terms of muscular, dehydration, stress, and whatnot. For migraines, for patients who have pre-existing migraines, as we know, there's an estrogen component to migraines. So for that, oftentimes migraines do improve during pregnancy because there is no more fluctuation of that estrogen. However, patients can still get migraine exacerbation during pregnancy. And again, the risk and benefit of triptan use really depends on the OB and the neurologist that might be prescribing them. But again, counseling in terms of the risk benefit and if they would like to wait it out sort of thing. Most of the time, the patients who present with headaches are tension headaches. And I put relaxation in quotes because I thought this was funny. In one of the literature reviews that I had looked at for this, they said, relaxation therapies. And as we know, it's much easier said than done, especially when you're pregnant and you're worried where your headache is coming from. But again, it's the concept of the muscle tension that can cause pulling, especially along the trapezius muscle, and that can pull along the fascia and cause this like cervicogenic component to a headache. So relaxation techniques, again, Peloton. I do not get paid by Peloton, by the way. I'm just a fan, but Peloton has great meditation for prenatal patients as well. Sleep and stress management is an important component on counseling. Avoidance of triggers, if they can identify triggers, as well as biofeedback, and then medications such as acetaminophen. As we know, we don't routinely recommend anti-inflammatory medications or muscle relaxants. Sometimes I'll recommend lidocaine cream or compound cream to that area. Rarely, like I said, have I done trigger points, but every so often, if they need it, I'm more than happy to do them. I do them with just lidocaine, and I do it ultrasound guided, so they're fairly safe. And then heat and massage again for the tension headache component. Joint pain, again, can be very common due to that biomechanical changes that happen. These could be arthralgias in just one particular joint, but it can also be associated with other types of neuropathy or tendonitis and rheumatologic causes. If it's rheumatologic related, oftentimes we do know rheumatologic conditions do get better. But again, if there is issue with rheumatologic causes, again, we would focus on medications on top of conservative therapies. And if it's non-rheumatologic, we focus on conservative therapies, which we'll discuss. So like I said, the rheumatologic arthritis does get better for the most part during pregnancy, whereas lupus can increase in activity during pregnancy, and then both of them can have exacerbation postpartum as well. And overall, there could be generally an increased risk of other postpartum issues as well. So what types of joint pain do we see in the pain office? So knee pain is something that I have routinely seen for depending on the trimester. But again, this is again due to the changes in supportive ligaments. Oftentimes this could be patellofemoral syndrome, which is this non-specific anterior lateral sort of knee pain. For this, we would recommend physical therapy and bracing. Again, sometimes, rarely will I recommend lidocaine to that area. And then foot pain, this is again from fluid retention, weight gain from fluid retention, ligament laxity, and the pressure points on the foot. We again do patient counseling, recommend foot support, massage, but again, avoiding any areas that could stimulate labor. Heat, elevation, stretching, and then foot baths. Foot baths are great for patients who do have this. Leg and foot pain, so thigh pain, especially lateral thigh pain, that could be associated with meralgia paresthetica, which is entrapment of the lateral femoral cutaneous nerve. Leg cramps, very common in pregnancy. They can be disconcerting, but again, for the most part, we know that this is due to dehydration. It usually happens at night. And then most of the time we counsel on hydration, stretching, making sure nothing bad is going on, of course, still, heat and massage. And I will say for leg and foot pain, again, oftentimes patients will be referred to me for sciatica. Now, I put sciatica again in quotes because sciatica in non-pregnant patients is often radicular pain from some sort of nerve root compression, such as L4-5, S1. But sciatica is something that can happen in terms of sciatic nerve compression in our pregnant patients. So sciatica is something that we kind of say in terms of pain in the lower back and lower going down the leg, but in non-pregnant patients, like I said, it's usually nerve root related, not associated with the sciatic nerve. But in our pregnant patients, when we say sciatica, it often is related to the sciatic nerve and caused by the compression of the baby's head, causing this area of pain. So again, it's important to rule out, is this sciatic nerve pain or is this L4-5-S1 dermatome distributed pain, right? Because if it's L4-5-S1 and posterior leg pain like that, then you're going to focus higher up on the spinal cord in terms of the disc area, versus if it is true sciatica from the sciatic nerve area, then you wouldn't do any sort of epidural related injection. Hand and wrist pain, so carpal tunnel, very common in pregnancy, can also persist postpartum as well. So pain along the median nerve, symptoms are often worse at night. And again, conservative treatment for these patients as well in terms of nighttime splinting, PT. I have, again, once done an injection with local and steroids in a patient who was pregnant. She had terrible carpal tunnel before pregnancy and then got only worse during pregnancy. So again, for patients where it's causing debilitating pain and issues with their functionality, it is something that we can do. And then also, I have seen one patient who proceeded to surgery as well by the time she got to the second trimester because it was terrible. So we do see this commonly, but again, it's risk stratification. If they're able to be managed conservatively, we focus on conservative management. Hand and wrist pain, this is mostly in the postpartum period, but again, from lifting the infant, you can see pain along the abductor pollicis longus tendon. Most of the time, this is self-limiting. We usually recommend splinting. Anti-inflammatories work like a charm in the postpartum period. And then rarely do we, again, do steroid injections, but they also work well for these. Neuropathic pain, so again, neuropathic pain could be like the carpal tunnel that we spoke about, neuralgia paresthetica, which is lateral femoral cutaneous nerve entrapment, which is right along over here. So you'll see this lateral thigh pain that patients will report. Oh. Sorry about that. Everyone can see my slides again?
Yes, we can.
Perfect. So again, for lateral femoral cutaneous nerve entrapment, conservative therapies, most of the time, this is stretching, yoga, PT. Rarely, and I have never particularly had to do this, but rarely will we need to do local infiltration if there is refractory pain. These are fairly straightforward injections. They're fascial plain box. So again, ultrasound right over that hip area, very quick injection with a little bit of numbing medication and steroids. So it's a fairly safe injection. I just haven't had to do it in a pregnant patient. Intercostal neuralgia we'll see every so often. This is one of those things that really drives a lot of pregnant women crazy because the feet are just kicking at the ribs and they're like, when is this going to get better? So yes, it's very uncomfortable and disconcerting, but it does get better. Most of the time, we recommend stretching. Sometimes we'll recommend creams in that area and patches, rarely injections. Intercostal nerve blocks are fairly safe, but routinely we don't like to do them, especially on pregnant patients. But if they're needed, they are still fairly safe. Other types of chest wall pain. So again, we want to rule out cardiac issues, pulmonary issues if they're reporting chest wall pain. But outside of that, sometimes they can have costochondritis, and this can persist postpartum as well as mechanical rib pain, rib fractures from osteoporotic or traumatic lesions. And for this, again, we recommend lidocaine patch, potentially TENS unit, again, really assessing which area. If it's more lateral, I have recommended it before. And again, neuropathic agents, risk-benefit analysis, and heat and ice. Abdominal wall pain, rule out all the other causes. As you can see is the theme here. It can be anterior cutaneous nerve entrapment, which is localized. I do Carnets, which is, again, kind of assessing which localized area they're having this muscle irritation and nerve entrapment. But again, most of the time, the treatment is conservative. Hip pain, rarely do we see osteonecrosis of the femoral head, but that's this picture over here. Most of the time, if it is true osteonecrosis, it's a surgical urgency, because this does not improve with time. If it's osteoporosis, the transient osteoporosis of the hip, then most of the time it does resolve. And then other types of hip pain, for the most part, conservative treatment. pelvic pain. And I believe I'm giving a lecture on this to the residents next week, which I'm looking forward to as well. So I do see pelvic pain during pregnancy and then most often after pregnancy. So we know that this can be common during pregnancy, but also can persist post-pregnancy. And the causes are very variable in terms of pelvic floor dysfunction, pelvic girdle pain, pudendal nerve irritation. And this is a picture of the pudendal nerve traversing between the sacrotuberous sacrospinous ligaments posteriorly along the buttock, which is how we access the pudendal nerve. Could be also associated with coxodynia or levator ani syndrome. Pelvic girdle pain is something I see commonly in pregnancy, postpartum, all of it. Management of pelvic girdle pain during pregnancy and pelvic pain, and I say that very generally because we know that there are many different causes of it, but for the most part, it's a lot of patient education, ergonomic training modification, support belts, exercise, PT. And then postpartum pelvic floor dysfunction, which is a good part of my practice. A lot of this is, a lot of the pelvic pain does persist if it's pelvic floor dysfunction related. And that's stuff that we can help with. PT is the number one thing that I recommend if they haven't already. And all of you already amazing OBGYNs recommend PT. But if they happen to make it to my office and haven't been to PT, I recommend pelvic PT after they're cleared for internal work for almost everybody. And that's to get a good map of the pelvic floor in terms of understanding of the superficial and deep muscles, what's hypertonic, what's hypotonic, and doing the appropriate exercises to strengthen and relax the muscles as appropriate. They also would get appropriate ergonomic modification counseling. And if needed, if they have hypertonic pelvic floor, I can help with medications as well as pelvic floor trigger points. So managing chronic pain during pregnancy. So patients who are on pre-existing opioids, for the most part, can continue if they find out that they're pregnant. The most evidence that we have is on methadone. And for the most part, methadone and buprenorphine are safe to continue, especially in opioid use disorder. We don't routinely recommend stopping either of these for patients who have opioid use disorder. But for patients who are on other types of medications, such as methadone or hydromorphone, oxycodone, whatever it may be, we are now starting to see some more evidence that buprenorphine might be safer, lower risk of neonatal abstinence syndrome, in which case I particularly don't do them yet. I'm interested to know if anybody else, but I know that there are other physicians in the addiction world that can help with micro-induction to transition them from whatever amount of methadone they're on to buprenorphine, which is going to be safer potentially for the neonate. And then other opioids, for the most part, if they're lower doses, can be continued, and we continue all types of supportive treatment. So a typical visit in our office, I go through, this is kind of like a slide from another lecture that I use, but basically I try to remind my fellows and my colleagues too that, there are many differences in pain expression and the pain experience. And we know there's biological factors, psychological factors, social factors that all contribute to the pain experience. And in our pain visit, we want to make sure that we are trying to address as many of those that we can help with as possible. We're not going to take on everything, but whatever we can help with in terms of positive reinforcement, in terms of, positive motivation and support that we can help if they have an advocate in the room, such as their husband or their daughter or whatever, that, encouraging them to play a role in it too. I go through the muscles, nerves, and bone and tissue concept in terms of, after the labor, you had some sort of tear, and now you were having post-scarring pain. This could be related to the muscle, but it can entrap the nerves and cause different types of pain. Prolonged labor, pushing, that can cause, pelvic girdle pain to persist as well. So again, I take them through the concept of what muscles might be involved, what nerves, what bone, and then tissue stuff is more so my amazing OBGYN colleagues. But if there is any concern for persistent uterus or bladder or other stuff, I refer them back appropriately. And then a typical visit with me in terms of counseling, regardless of what type of patient. I go through a big part of my patient education revolves around lifestyle medicine. So I'm certified in lifestyle medicine, as Dr. Merjanian said, which is an area of medicine that focuses on basically how patients can take control of their care to prevent chronic diseases, including chronic pain, right? So we focus on how to incorporate whole plant-based food, physical activity, stress management, sleep, positive relationships, and whatnot. So as I said, we know pain is biopsychosocial. It's a biopsychosocial experience with different factors that can impact the pain experience. So a big part of my my consult with them is understanding what things are causing their pain to be worse. What can I help with? If this is somebody that does have chronic constipation making their pelvic floor dysfunction worse, but they're eating a high sugar diet, maybe that's one thing that I can help counsel them on during this visit and give them like a homework assignment for their next visit to discuss. I encourage pain diaries to find that cause and effect, so patients can feel like they're empowered and play a role in their healthcare and not just passive recipients. Some of my patients do enjoy the pain diary. They feel like they have homework and they come back and they show me what they did, what made it worse, what made it better. I counsel them on, once they do identify the triggers, what types of positions that make it worse, sitting, sitting on hard surfaces, standing, whatever it may be, diaphragmatic breathing, squatty potty, all of that. And then a big part of my consult is making sure that they go to PT and encouraging the role that pelvic PT plays in their treatment plan. A lot of my male patients especially are very reluctant to go to PT, and part of my visit with them is telling them why it's important, what it's going to do, show them my pelvic model, show them the muscles, and see what role it's going to play. So again, giving them that hook and that buy-in for why pelvic PT is going to be important for them to continue. And then in terms of, what medications they might need that might play a role, what injections potentially, and rarely do we need to go to invasive therapies. But this is kind of a skeleton framework for how I take them through their pain visit. Okay, I think I finished on time. Thank you everybody for listening to me. I'm more than happy to take questions. Like Dr. Merjanian said, I do have a podcast, and a lot of my podcast actually focuses on patient education, including pain during pregnancy, labor epidurals, breastfeeding, and whatnot. So either way, if this is something that may help some of your patients, please feel free to guide them to there. I think it helps some patients feel better before they present to the labor and delivery area or to their pain consult, to know what a general sort of visit to look forward to. Thank you again.
Thank you so much, Dr. Patel, for an excellent presentation. Does anyone have any questions?
Hey, Dr. Patel, it's Todd Rosen. Thank you so much for like a super great talk. And yeah, you're in obviously one of the hardest areas to make a difference with a very frustrating patient population. And you can help sometimes, but often we don't. And yeah, I think there's a special place in heaven for you for the work that you do. This is my question. So a lot of our patients come with carpal tunnel syndrome. Like you said, the prevalence is very high. And we usually have just said, well, it'll get better when the pregnancy's over. We give them a brace and then we say, we're done. But do you have a specific strategy that you employ for carpal tunnel syndrome? And then would it be appropriate if we do some conservative measures and they are not effective to send to you for injections or for further evaluation?
Absolutely. Thank you for your kind words. For patients who have done the splinting, who may have done PT and it still persists and it's only going to potentially get worse with fluid retention as pregnancy persists, then yes, again, this is like an office-based procedure. I just pop on an ultrasound and I can inject some numbing medication as well as steroids. So again, if they fail conservative measures and it's causing disability and we only anticipate for it to get worse, I can do it in the office.
And then after you do your injection, how long would a pregnant patient typically have relief from her pain before they might need a second procedure?
That's a great question and my least favorite question, because as we know, the effects of steroids can be very variable. For some patients, it's one injection and, months of relief. For some, I do the steroids and 3 weeks later, they'll be back and say that, the pain is coming back. So it really is very variable. Ideally, the steroids can last weeks, if not months, but ideally weeks, usually weeks.
Sorry, one more question. Do you tend to use fluorinated or unfluorinated steroids? Like, would you give hydrocortisone, or do you typically use something like beta or dexamethasone when you do your injections?
Usually I use beta or dex, whatever is available usually, but usually we have, actually, I take that back because I had beta at Sinai. I use beta a lot. Here I have methyl prednisolone mostly, and then dexamethasone we almost always have. So if we have dex, I'll use dex.
Yeah, and the reason I was asking that question is that the non-fluorinated steroids, like your methylprednisolone or methylprednisone, don't cross the placenta, but the fluorinated ones do. So we always ask that if you can have the same therapeutic effect with the non-fluorinated steroids, that we use those preferentially.
Excellent. That's really good to know. So that would be something that I can use to change my practice as well. I have a question for the audience. What would be your thoughts on using something like diclofenac gel for certain types of joint pain in patients who are pregnant?
So diclofenac is a non-steroidal, is that correct?
Mhm.
Yeah, for any of us to answer that, we'd have to probably go to a textbook and see what the systemic absorption is. Like certainly in the first or the second trimester, probably not a big deal. But in
Right.
the third trimester, like those things are verboten, and we would avoid them like the plague. But after researching it some, we might have a different opinion.
Okay. Yeah, because I've always been intrigued, and again, I refer them back to the OB and say, if they are okay with it, this is potentially a possibility. But there's low systemic absorption if used over joints like the knee joint, as well as the hip joint and shoulder joint. But every so often, I don't use it over muscle because there could still be absorption, but especially over something like the knee joint, if they're having that and there's low systemic absorption, it's something good to consider. So I'd be intrigued to know if that would be something that we might be able to use, but not in the third trimester.
Hi, Dr. Patel. This is Ruchira. I'm one of the
Hi.
MFNs. Lovely to hear you again after our panel discussion. So my question, I mean, you asked this, you mentioned this couple times that you avoid the acupressure points in the sole of the foot that would avoid labor. I'm intrigued by that. What is the data on that? Are there pressure points which can trigger labor?
Yes, so there are potentially points, acupuncture points near the ankle that can induce labor, as well as below the foot. Some of this is from Eastern medicine. So again, for total sort of out of all abundance of precaution, we usually say avoid foot massages, especially towards the end of labor, towards the end of the pregnancy, excuse me. But there is some data that it might induce labor, but out of an abundance of precaution, I do counsel them not to.
Actually, one of the points you was in your slide, Dr. Patel, was the BL67 point at the outside of the small toe. And that can actually be used to flip the baby too. So if you're doing that foot massage, you might actually flip a baby from vertex to breech. If it's breech, it's fine. But yeah, there's actually a big RCT that was published around 2000 in JAMA that showed if you start that at like 32 weeks, you have fewer breaches at term. Yeah, we prescribe that type of therapy sometimes to help our patients vert their babies to vertex without doing it manually.
Very interesting.
I'll speak for the last time. I'm sorry for talking so much. Thank you so much for what you do. It's amazing that we have you here to help our patients, because there are not enough physicians who treat pain in our postpartum, in all stages of life, especially in pregnancy. So thank you for being available. And I'm sure as a result of this talk, referrals to you will go up, and you will be inundated, and you'll be unhappy that you spoke to us today. Yeah. So yeah, I had a question, but I forgot it. I'm just going to say thank you again for presenting to our group, and it's super helpful and super meaningful. Thank you.
My pleasure. I mean, I'm very happy to be here. I've been very warmly welcomed, and you have an amazing group of people with you, and I'm just excited to collaborate. My email is right here. I'm also on social media. I do patient education stuff, and my cell phone is available to a lot of you, and I'm more than happy to give it to anybody who wants it. And you can text, call anytime that I can help with anything at all.
Awesome. Thank you so much, Dr. Patel. We're going
My
to go
pleasure.
ahead and thank you. We're going to go ahead and end it here, and just wishing everyone a great day. Thank you.